We're live. Hey, good morning. Welcome to Doc Talk Live. I'm Dr. Brad Goodman. I'm with Dr. Eghbalieh, Navid Eghbalieh. Navid is in Los Angeles, California. Thank you for remoting in this morning. Navid is a radiologist, and we're going to talk a little bit about a particular type of treatment for broken spine bones when folks have cancer. But welcome. It's a pleasure to have you, Navid.
Good morning, Dr. Goodman. Thank you so much for having me. It's a pleasure to be here. I'm excited to talk about this and spread the word and, educate more people about it.
Tell me a little bit about what you do as a radiologist and how you found your path.
Okay, I'll try to abbreviate it down for you. So radiology is, everybody thinks of radiology as the physicians that read the images, right? Where there's MRIs, X-rays, CTs, ultrasound. There are subspecialty or its own specialty now within in radiology that's referred to as interventional radiology. And basically it's a subspecialty, and again, now it's its own specialty where you go under extra years of training and you do minimally invasive surgical procedures under image guidance. So I was always very keen, I had my own path that led me to medicine and wanted to be a surgeon, but I'm a very visual person, and I got exposed to radiology, and it was always like trying to figure out a diagnostic puzzle with images, and I found that very exciting. But what really fascinated me was the specialty where you could actually do invasive procedures, and I'm a very hands-on guy, so it kind of led me that path, and a big part of what I do is what we refer to as interventional oncology. So it's treating people with all types of cancers, like liver cancers. We deliver chemo or radiation directly to the feeding vessels. Lung cancers, we can burn or ablate them. Same with liver cancers, kidney cancers. It's a pretty fascinating field, and I don't think I would have enjoyed medicine if it was 20 years ago without the technology. The technology makes it that much more exciting, and everything we're doing is, at most you're making a centimeter incision, even usually smaller, and doing big things.
So we were going to talk a little bit about treating spinal fractures due to cancer. And there's a procedure called kyphoplasty, which perhaps a lot of viewers will be familiar with. But there's something you add to the kyphoplasty called OseoCool. And I've got a lot of questions for you, but first, sort of describe what kyphoplasty is for our listeners and our viewers. And if folks, there's about 6 people watching, but if you all have questions, feel free to type them in. If you catch this on a rebroadcast, certainly ask your questions. I'll try to get to them later, but go ahead, Navid.
So just to kind of start in a general thing, osteoporosis, right? Everybody gets their bones thin out as you age. And more than 10 million Americans every year are affected by osteoporosis. And what osteoporosis usually leads to, not usually, but it can happen with osteoporosis, is you could have a fracture of your vertebra or your spine. So on going by the osteoporosis society or foundation, they say about 750,000 Americans every year suffer from vertebral body or spine fractures. And why that's important is a lot of times people think of a back fracture from trauma or some severe impact. But as our bones become less dense or osteoporotic, I've had patients that say I sneezed really hard and they fracture their back, or their routine activities that they do and they pick up something and they fracture their back. They take a step down, the regular 2 steps in front of their house, they fracture their back. And a back fracture, spine fracture, is extremely debilitating. So besides the pain, your daily activities, and what happens with that, and just to give an example of how severe it is, I'll never forget this. I had a female patient that said, I've had 5 children and kidney stones. And she's like, the pain of this back fracture is worse than having a kidney stone while giving birth. I was like, wow, that's, I've never experienced either of those. And it was like, that's pretty severe. So what technology and what's come about it is this procedure you refer to as kyphoplasty, or which is bone cementing. And, people think of back fractures and requiring big surgeries, right? They got to cut you open, go in there, put hardware, or basically fix the fracture. But with the technology getting better and the advent of all these new devices, with one or two less than a centimeter, a couple millimeter size holes, we go through the back under image guidance, usually live x-ray, into the fracture. So everything is being watched and you're doing it safely. Get these two introducer needles, and the needles are the size of like a big pen, a traditional big pen, actually probably a little bit thinner than that. You get into the fracture itself, and imagine like a vertebral body fracture is a soda can. So a soda can crushes, and there's two parts of that fracture that really cause pain, but one is more severe. One is you're losing the height, so it's compressing on the nerves or compression and losing that stability. The other big component is what we call the microfractures. So imagine just like an earthquake or all the things moving. When you have a fracture, you have all these tiny little fracture fragments. And every movement, you get these fracture fragments rubbing on each other. That's why if people see like an orthopedic surgeon or a neurosurgeon, when they have a back fracture, they put them in a back brace to limit that motion or movement. So
the problem is we have to breathe.
That's right. Believe it or not, actually, there are a lot. I've had patients, if it's higher up too, they say, Doc, I have a hard time taking in a deep breath. It hurts. And these are very active patients that are completely, debilitated by this. So, people go and sometimes they put them in a back brace. They put them on pain medication. So, we talk about opioid use. It takes up to 6 months or even more, sometimes less for some people, to have to tolerate this pain and be in this back brace and dependent on pain medication. But when we go in through the procedure I described, we basically push open a little cavity. Imagine just popping that soda can reference we made with a balloon. And while we've pushed it open, we push in bone cement. And what that cement does, it basically stabilizes those microfractures we talked about and gives a little bit more support as well. And the cement hardens within 20 minutes. The procedure never takes more than an hour, usually less than that. People can either come in, let's say if someone comes in through the ER or they're seeing their primary care doc, and we've discovered that they have a fracture, they could do this as a routine outpatient procedure. They come in that morning. The procedure takes about an hour. We watch them for maybe an hour or two just to keep them flat. They eat and they go home that same day. And
the hardest part about the procedure is getting it approved by the insurance company.
That's a whole different topic, but absolutely, yeah. That's probably my least favorite part
about that procedure.
Yes.
It really is a simple procedure. Now, commonly done for folks with thin bones or osteoporosis. Take this a step further and talk to us a little bit about, how you select patients with cancer and how this procedure gets modified.
Okay, that's a very good question. So we'll look at it through two different ways. One, somebody comes in and they have a fracture, right? They get the traditional workup. They'll get an x-ray, usually an MRI of their lumbar spine to see, one, determine that there is a fracture, determine the age of the fracture. And as we get older, we always worry about, God forbid, a metastatic component where the cancer could spread to the bones. So if we think about the primary cancers, such as breast cancer, lung cancer, prostate cancer, 60 to 80% of those patients will at some point have a spread or metastases to the bone. And what could happen is, we talked about the bones fracturing because they're less dense or osteoporotic. When the cancer spreads to the bone, the cancer replaces the traditional bone matrix with cancer. So that traditional bone that's there now is replaced with cancer, which is almost like not having true bone. And you could still have a fracture happen, or what we refer to as a pathologic fracture. So when we do this procedure, almost always, when I introduce those two needles I talked to you about, we take a sample or a biopsy, a little piece of the bone that will get analyzed by the physicians that look under a microscope, the pathologists, to determine is there any cancer there or not. And that's one way, because sometimes that's how it's discovered, right? The patient is doing fine, no issues, they have a back fracture, and then we determine, oh my God, there is a metastatic disease, the cancer has spread. The other way is working very closely, and I'm very fortunate I have wonderful oncologists and radiation oncologists that we work with. So people that have known history, sometimes they have that fracture happen with the disease, and they're usually getting systemic chemotherapy and radiation therapy by the radiation oncologist with external beam radiation. But we work together, and they refer the patients, they go, look, they have a fracture, but we want you to also treat the fracture. And this is alluding to what the OseoCool system of Medtronic is. Medtronic is a company, like just one of them, that has created this kyphoplasty system, I think, since 1998. And as technology has gotten better, through that existing system now, they have designed these antennas, or what we call radio frequency antennas. Radio frequency is thermal or heat ablation. Just think about radio waves kind of, going back and forth, and it causes heat, and that's how you burn the tumor. So through their system, so through the same procedure that we usually do, we go in with these antennas. The machine figures out the circumference or how much of the bone it needs to burn. It measures it, calculates it, and you're adding no more than 10 to 15 minutes at most to the procedure before we put the cement. So we go in, we burn all of the cancer, then we do the kyphoplasty to follow. And it's incredible, because I do a lot of follow-up with the imaging, with the referring physicians, and it's quite spectacular, the results you get, because a lot of times people would just come in to fix the fracture, but you still have to deal with the cancer as well. Now we're able to not only treat the fracture, burn the tumor within that bone, and this could be done while somebody is on chemotherapy or radiation, before chemotherapy or radiation, or after, and it doesn't limit that process.
Why wouldn't the cement itself be enough to burn the tumor?
So the cement itself, what it does is, the cement is just pushing things and filling a cavity. But before we put the cement in, we put these two antennas. The antennas burn everything, all the cancer that's in that area. We take those antennas out, and then we go in with the cement. So it's almost like adding one step before putting the cement.
Right, but why would the cement itself, the liquefied cement, gets very hot? Why would that not be enough to burn the tumor?
That's also a very good question. So imagine if we have a cavity here, this big. Usually when we push the cement in, the cement will probably only fill in a certain amount. You're never going to fill in the whole cavity or the entire, the whole bone. So to answer your question, when you do the frequency ablation, you're going to get all the edges, so the entire area. So even though you're just putting, let's say, cement in this spot, the rest of it is going to get burned, where traditionally the cement won't reach all of it.
How do you determine whether to do this procedure versus radiation to the spine for these metastases, or do you do both?
That's a very good question. So in my practice, we do both. And again, it's the relationship I have with the oncologist, and specifically our radiation oncologist. So we always work together. So my goal, or one thing that I love and I think it's important in medicine, I'm sure you can allude to as well, is multidisciplinary approach. I'm a big believer that we have a lot of subspecialties and people focus on this organ or this body part. But if we work collectively, so I work with our radiation oncologists, and we almost always do both. And what they do is they take into account what I do, and they change the amount of the radiation that they're going to deliver, right? Or based off of how much I was able to burn. So that's a very good question, and that's an important thing. It's not in my opinion, I don't think it should replace the traditional things that work. This is only like an additive or basically synchronous to further help that patient. And that's why we have such a good relationship with our referring docs, because we always work together to get the best outcome for our patients.
So what you're basically saying is that perhaps by doing the OseoCool kyphoplasty treatment, you may limit the amount of radiation that the patient will thereby subsequently have to continue to have.
Absolutely, 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 and that all determines, how much of the bones, how many of the bones are involved. But absolutely, absolutely.
I think that hopefully we'll be able to maybe get a patient of yours, I don't know, to tell their story. In fact, we were going to try to do that today, to have a patient, but they're getting chemotherapy this morning, I believe, so that didn't.
Correct.
But perhaps you could tell us about a patient and sort of bring it home for our viewers.
Sure. Well, the person you're referring to is a gentleman named Jim. He's in his mid-80s. When I first met him, just to take a step back, this is a very active guy. He's served as an Army paratrooper. He's played football. He's been an engineer in the Navy. He cuts his own, grass, mows his own lawn. Very active. In some ways, when I joked with him, I was like, Jim, I think you do more in a day than I do physically, And he had prostate cancer that he's been battling for 20 years, but pretty much surviving or fighting that cancer for 20 years. And he ended up having a spread or metastases to the bone and having a fracture. And he basically said he went from being a very active guy, moving around, doing everything, to completely limited, not being able to do his routine activities. And you have to think about the psychological component that goes with that as well. People are used to doing things every day, and now not being able to do those things has an impact. Again, the opioid part, which he had even mentioned to me, is that, Doc, I don't feel good taking this medication. And the way I would usually ask, and I'll refer to Jim, is like, okay, he describes his pain as 10 out of 10. And I'm like, well, how much relief do you get with opioids? And he's like, maybe I'll get it down to, a 4 to 6, and that's for a short period of time. But then I feel groggy. He gets, we all know, constipated, right, backed up because of the opioids, has to continuously take them. And he didn't like it because he doesn't like not being fully, with it. And when I saw him, I genuinely felt I could feel his pain. And just to give you a background, somebody who was very active, completely immobilized, not able to do his routine activities, psychologically being affected, becoming dependent on pain medication. And I rushed his procedure to get him in. And I do that very often because I feel guilty if I'm making somebody have to wait on my schedule. So we actually brought him in I had a day off. I got him approved, which was important. And it's something nice with this procedure, actually. It's very well, especially with Medicare, it's very well received and expected. There's tons of years of data. So it's one of the much easier, simpler ones to get approved. I've never really had a problem not getting it. So it's almost 99% of the time I've gotten.
You're referring to patients with cancer now, not patients with just soft bones.
Both, believe it or not, both. Okay. The hardest, by the time it gets to me, now there may be an issue, on your guys' end, I don't know, but by the time it gets to me, it's usually good to go. I do have my own clinic, and that's just very different for, radiologists don't. So I have my own clinic, I see patients, and for the last 3 years, because it's taken me a long time to build that, private clinic practice while doing the procedures, I've been successful, but I'm sure you'll allude to other,
With prostate cancer, do you ever notice actually the bones are stronger or harder to tap in the
Absolutely. Yes. So they get thicker. Now so they are harder to get into, but the misconception sometimes is people like, well, if it's more dense or thicker, isn't it more protected? No, it's the same steps as not having that bone matrix. It is harder to get into, and you bring up a very good point. A kyphoplasty, or getting into the spine, is really dependent on how acute or when the fracture happened. So if we get it within the first month, maybe up to 2 months, getting in, easy. The longer it sits, the harder it is to get in, because I've had patients who 6 months ago, they've had a fracture, right? And their practitioner didn't even know about kyphoplasty. Believe it or not, a lot of people don't know about it. And that's why I'm here today, is to make sure to help spread the word. And by the time they got to me, they're still having pain, and we still were able to do the procedure. But to allude to what you're saying, it's much harder to get into. The amount of relief that you get is, not as dramatic in terms of how much you get. So in terms of Jim's case, when he came in, it was pretty fresh. We got him in, and almost 90% of my patients, 80 to 90%, right after the procedure, they're 100% better, 90 to 100% better. I usually tell patients it may take up to 3 days because, we're going through skin, we're going through muscle. So just my part of the procedure, you get sore, right? Imagine people putting something through your back, but within 3 days, they get better. And a lot of questions I get is, well, how much improvement do you see? And how I categorize or classify it for patients is just like how I asked Jim. I go, so your pain is 10 out of 10. You take pain meds, you get to a 4 to 6 out of 10 for a few hours. I was like, if I do this procedure, and I can guarantee you at a minimum, you will get 50% improvement, if not 90 to 100. But let's say the least I was able to do was 50%. Would you be open, or would you be okay with doing it? Dr. Goodman, I've never had a patient, and when you experience 10 out of 10 pain, say, absolutely, because they think about it 50% better. Even if they have to take pain meds, their pain is gone, right? And that's how I approach every patient.
And patients know that in skilled hands, the complications from this is virtually non-existent.
Correct.
Not that there aren't complications with any procedure, but in general, this is a procedure with very low complications.
Absolutely.
So I'm curious about the artwork behind you. Please tell me about the work of art behind you.
Sure. Before I went into medicine, I painted. I had actually my own art gallery. I don't know how much of my time or your time I'm going to take, but I'll try to kind of go through it a little quickly. But I'm the youngest of 3 brothers, and my parents were very adamant about making sure all of us found something that we enjoyed, that we had time on our own time to do as kind of like an escape. So, for example, my eldest brother is remarkable with the piano, my middle brother with the violin. I tried every instrument except the guitar, but I think my parents were losing hope for a little bit. And I had a book report in 6th grade, and if most people remember, you draw like a picture of what you read, and you show it, and my mom saw it, and she's like, oh, hey, what is that? And I was like, oh, I drew it for this book report. And she's like, oh, show me. She wanted to see if I had traced it, etc. And when I showed it to her, she was like, oh, okay. And her and my dad had this conversation, like, oh, maybe this is his thing. So they took a risk. There was this famous artist that they knew who had a terrible reputation in terms of being very blunt. When you picture how could someone like cut off their ear and mail it to someone, right? Like a Van Gogh kind of thing. This was the guy. And he's notorious for telling parents in front of the kid, like, your son or daughter has no talent and I will never teach them.
Who was this artist?
This is Dr. Payman. So Payman. And he was the main artist for the Shah of Iran. So I'm half Greek, half Persian. My dad is Persian. And he was the main artist for the Shah. This is before the revolution in Iran. And he was here, and he has this little kind of art gallery of his. And I will never forget that day. I showed up in this dark room. This guy is no affect. Gave me 3 pictures: a landscape, a bird, and a woman's face. And he said, draw it and come back. Okay. And him and my parents were walking back, and my parents are complete opposites. My dad is the most confident, fearless man I've ever met in my life. Like, nothing scares him. And my mom is the most emotional person, right? Over a sad commercial, she'll get teary-eyed. So she can't hide her emotions. And I could see by she had this like giggly look on her face. I was like, okay, this is good. And was one of the very first times I felt nervousness. I've never really felt that. And he came in and he took me on as his student. And after a while, I started helping him teach. And then I opened up my own art gallery and went to college, majored in art. And then I got exposed through different things in life that led me to medicine, personal experiences. I had a friend that passed away. I was there and I didn't know what to do. And and looking back, there was nothing I could have done, but I was always very upset that I didn't have basic skills. So I went and learned some basic skills, became an EMT, felt I needed to do more, became a paramedic. While I was doing that, I added on a second major in college because I was like, I need to learn the sciences, and went on from there and sold my art gallery, believe it or not, which was a big step for me going into medical school, but it was important. I think it was a big part of it was being a paramedic, and I used to work and always feel like there was more that I needed or could do.
Tell me what's behind you.
I'll show you that one. I'm going to show you another one. I think that let me grab it real quick, okay?
Okay.
All right. So this one is, I think, one of my most favorite ones. I don't know if you guys can see that clearly. So a big part of what I did, just to give you an idea of why radiology, I guess, made sense. I'm a very visual person. So going into, and I've done a lot of landscapes, and I'll show you those, but I went into really capturing people's faces and emotions. And I started taking it to the next level where, and this happened when I was an undergrad at UCLA, I started doing paintings and having shows and raising money for homeless shelters, homeless single mothers, homeless children. This is during, remember, the Haiti earthquake that happened, and we had gone, and there was Jennifer Brown was a photographer who was with us. And I'll never forget when I was there, I saw this moment. I asked her, can you capture this, because she was an incredible photographer. And I took it and I painted this painting, and we raised thousands of dollars to help out. And we would do this. And just to give you an example, and most people see this and they think it's, someone with his family or his friends. And this is how I perceived it. I remember when I saw it, I said, most of us in our life is being cared for or comforted by someone, right? Someone is taking care of us. And something bad happens, whether it's a traumatic effect or, God forbid, a loss in the family, and you get scared. So you're nervous, right? Something bad happens to you. And then the next step is you break down and you cry. And something that really impacted me is what happened with most people is the next emotion is things kind of fade away or it's forgotten about. And you see he's kind of disappearing in the background. And that really had an impact on me. And that's kind of where art has taken me today, because a lot of people talk about, well, how do you have time or do you make time? I really do. I come home, I lose a lot of sleep, and Dr. Goodman will attest to this. We don't sleep enough. But I really do try to, and I think it's very important. It keeps me very balanced and happy, and I still do a lot of fundraising with my art. And that makes me even have a bigger drive, because when I had an art gallery, people would pay me to paint a family portrait, and I loved it, but it was not as humbling, or the amount of emotion or impact it had on me wasn't the same as it is now.
My fiance is an oil painter.
Oh, very good.
So I'll show off the one behind me.
Yeah, please.
I'm trying to get her to go into medical art.
Yes.
So I don't know if you can see the spine.
Wow.
But that's an oil.
That's really good.
Yeah. So, she mostly does. She comes from the portraiture realm, like you.
Right.
But and you being a radiologist, there's so many cool images that are abstracts, really.
Correct.
But to you, they're not abstract. But to the average viewer, they're abstract. So, she's working on the spinal cord now, sort of a cross section through the dorsal horns and the ventral horns, and to anybody else, it's a piece of abstract art. To me, it's a spinal cord.
Right.
So,
no, that is beautiful. Please encourage her, because and that actually, it's funny. I mean, not funny, but we're talking about spine fractures.
Right.
And that's so relevant.
Sure.
And
Yeah. So the fracture is obviously, you know, this will give you a sense of scale, right?
oh,
But the fractures are in here. This is that Coke can you were referring to,
correct.
that you would treat the tumor inside. It's pretty big, right?
Yeah, I'm actually happy that you stood up to show us because I didn't appreciate the scale or how big it was. And when you're doing an oil painting, the bigger it gets, the harder and more work because the details are popping out more. So it requires more of an effort. That's beautiful.
Yeah, I'll have to
Very
put some.
good.
So tell me about the one behind you.
So this one is a landscape. I don't know if you can kind of see it or not. And we would, when I was younger, parents would go out and take trips, like to Lake Tahoe. And I've always been active. My brothers were like big snowboarders, and I was kind of like a little bit more dorky. And I would go and bring art and sit outside and paint, and that's kind of where it's taken me. I mean, it's funny, my mom created a website for me so she could have like some of the paintings I've done, because she wants to share it with her friends and everything like that. And actually probably has the most of my paintings at their place. I try to get it all back. She's like, oh, no, when you have your own family and kids, we'll give it to you. But, or she keeps it, I think, to make sure I keep going there and seeing them to see my own artwork. But it's pretty fascinating.
This is where exactly? This is in Colorado.
In Lake Tahoe.
Tahoe, okay.
Yeah, Lake Tahoe. And then I think, a big part of, like you said, the abstract component, or, that's why radiology made so much sense to me. It's like when I did biochemistry, visually, or the 3D component really impacts me. It makes sense. And when I'm doing procedures under imaging or looking at imaging, like you said, like it just looks like a bunch of mush sometimes, right? Even like an ultrasound you're looking at, it resonates with me, and it keeps me engaged and excited, because every procedure, every image I read, every case, again, it's like this diagnostic puzzle that you're trying to figure out. And taking it a step further, there's nothing more gratifying. We all do lots of different things, and we wait to see the results. And one of the few things I do that I get instant gratification, instant results, is the kyphoplasty, is using the OseoCool to kill the tumor. Seeing somebody who's not able, like Jim, not able to walk or move and suffering, to getting up and walking. I had another gentleman who, he couldn't sit, would hurt him. Laying down would hurt him. He was kind of on this like recliner that he would use. And he basically told me, and he ended up actually getting a clot, a DVT in his leg, because he wasn't moving, which he ended up having to get treatment for. But the second we did the kyphoplasty, I'll never forget, he just got up, and I was like, whoa, just slowly, just trying to encourage him. But he was almost like he totally forgot he was in pain and debilitated. And it's an incredible, we're very fortunate. I'm very fortunate. I love what I do. So
I hope I get to meet you in person one day. I'm curious because I'm a physiatrist. I do intervention.
Right.
It's probably a bit obvious to you that I do intervention based on my questions. But my sort of society would be SIS.
Okay.
What is your society? And SIS, for the viewers, is Spinal Intervention Society. But what is your main society?
It's almost identical to yours. It's SIR. So Society of Interventional Radiology.
Interesting.
Yeah. So
Did you know Doug Fenton?
Yes.
Okay.
Yes.
So Doug and I went to high school together.
Really?
Such a small world. Yeah. And we were in a very small class. So, but I'm a physiatrist. Obviously, he's a radiologist. And
right.
But
where'd you guys, just so I didn't, where did you grow up?
I grew up in Birmingham, Michigan.
Okay.
Or Detroit, Michigan. Yeah.
All right. Cold.
Very. I prefer Birmingham.
I'm a California, LA guy, so I don't do well in cold
Alabama,
weather.
that's for
Oh,
sure.
you? Okay.
Yeah.
Okay. That's good.
And actually, my mentor was a radiologist,
Really?
Charles April. I don't know if that name is familiar,
No.
But yeah, Charlie April was my mentor from New Orleans, and this goes back to the early '90s, before we had fellowships, and and these procedures existed. Really.
Correct. And everybody did everything pretty
Right.
much as well, right? Right,
Yep.
right. Yeah,
Well, it was a pleasure, Navid, talking to you. I hope we get to do some more of these together down the road, talk about other treatments for cancer and interventions. And I'm a very visual person, so I'll plant that seed too. If we do more of these, think about how we can show images.
Sure, absolutely.
I know so I'm not very good with the computer, but there are ways of like sharing your screen, and you can put up various images on your screen so people can see, you know, an MRI or a PET scan or whatever it is. So there are ways.
I would love that, and I look forward to it. There is such a vast majority of not majority, vast, you know, treatments and procedures that are out there, and like you said, most people don't even know. And visual is very important. I mean, every one of my patients that I see, I do exactly what you said. I bring up the images because a picture will tell, you know.
Well, that's what makes this Facebook Live, Doc Talk Live, very unique. So it can be more than just a radio show. It can be more than just a podcast. It can actually incorporate images. And then ultimately, I don't see why people can't, you know, figure out how to log in and ask their own questions. I'm just facilitating a topic.
Right.
There's so much that this technology, this Zoom technology, if you call it that, can do to actually bring in the patient to instruct and be educational. So that's my long-term vision for this platform.
No, and thank you for doing this, because I know you're taking your time to do it, but it's important. It's important for patients. It's important for practitioners, and it goes a long way. So I really appreciate your time. Thank you for having me. I look forward to working with you as well in the future and meeting you in person. Probably in California if you come to California.
Eventually, we all go out west sometime.
All right.
Yeah, good. To visit. Good to talk to you.
Likewise. Thank you. Thank you, guys. Have a good one.
Bye-bye.
Bye-bye.
So stop.